week, and it's a real pleasure to have such a great lineup of speakers from all over the world. And our session today is going to be on the challenge of dealing with intraoperative complications, as we can see. The more you operate and the more you run into complications, and what makes a good surgeon is the way he deals with complications when they happen. Okay, so we'll introduce our first speaker, Dr. Ahmed Salam. He's an associate professor of retina uveitis and director of uveitis service in Jones Eye Institute, University of Arkansas in the United States. Please, Dr. Ahmed, can share your slide.
This is a very interesting case. It's actually, maybe probably I've made it more interesting or more complicated for myself. So this is a patient who comes on with a MAC-off retinal detachment. She is 50. And all what we can find is that two retinal breaks here. I don't know if you can see me like circling. One of them is a horseshoe tear and one of them is an operculated tear. So we know that this patient has PVD. And for some reason, I wanted to put a radial buckle on this patient. I thought I can nail this with a radial buckle. And I gave the patients all the options. And I've skewed her to choose a buckle. I've made her like feel that the buckle would be the best thing for her. She's on the young side, clear lens, and that's what we decided to do. And I kept dreaming of me putting a nice radial buckle there to get the two tears together. So that was the plan. So here we go. So this is the surgery here. So we open the conjunctiva, we hook the medial rectus and the inferior rectus, and we put one trocar just for elimination when needed, opposite to the detachment and the breaks. And this is here localization. And I already, usually before opening the eyes with buckle, I would do a 360 indentation one more time to make sure there are no other breaks in detached retina, so that the plan would not change. So I didn't find any other breaks. Those two breaks there, a bit posterior, but I thought I can get these on radial buckle, on a radial buckle, a 5mm buckle. And that was the plan. This from another surgery. So that's the technique I would do. I would localize and then go 1.5mm times the width of the buckle I chose. So it'd be like here about 7.5mm, put the suture. And it's usually a wide suture. And then after that, I would put the 5mm, press it, and that's what I would do. And then I may or may not drain, depending on how things are. And the plan was here and drain. So this is the plan, and that's what I wanted to do. The problem is when I opened and I localized the break, that's the situation here. You see, this is the issue. It's actually just very next to the vortex vein. So the question is what to do now. Shall I just try to put a buckle there, or cut the vortex vein, or leave the vortex vein, or change plans? And I just was not expecting it, because on examination, and you'll see later during the surgery, it didn't look like it was near the vortex vein, but the problem is the breaks were near the exit of the vortex vein from the eye. So just a reminder here, there's an anatomy picture just to show you what the position of the vortex vein in the oblique quadrants, more towards the vertical recti. And that was the situation in her. And we know that if you damage the vortex vein, you can get problems including choroidal detachment, vitreous inflammation, vitreous hemorrhage, and raised pressure, and even up to anterior segment ischemia. But what I really did not know, if I just damage one vortex vein, is this going to happen or not? So it's all going through my mind. So I just decided to back off and change the plan. So that's what we did. We now converted, we set up for vitrectomy, and we converted here. There's a 3-port vitrectomy. The fellow was happy because he took over and now he's doing it. And again, I'm just playing with the filters here, trying to annoy him. But here it is. So vitrectomy. She had PVD from the detachment. We tested with Scanalog, and she's phakic, so we're changing hands here. to remove the vitreous. And I'll show you my technique for retinal detachment that I do usually. Here we remove the operculum, and then we remove the flap of the tear just to remove traction. And then just continue with the vitrectomy. And then the important steps. So we finish the vitrectomy on both sides, and we do internal search, make sure no other breaks are there. And then internal search the other side, and we have the two breaks, and you will see them here. And you'll see them, they are away from the vortex vein. You'll see them there in a minute, but it's just the exit of the vortex vein. We found a small thing here, which ended up just being an operculum. We touched on was cryo, which probably was just not needed. And then here, he marked one of the breaks. And then we go under air. And the modification we do is just we drain only from the break. We do not drain over the disc, because the idea is that, or in my mind, if you drain over the disc, more fluid is shifted towards the posterior pole, and that may lead to retinal displacement. So I try to avoid that step. I just drain from the break, and that's it. And I end up with a smaller gas fill, but for this break, it's fine. So here, drainage from the break. And again, it's the fellow operating. And you can see now with the vortex vein, but it's just the exit of the vortex vein that was just behind the anterior break. We're draining from the posterior break here. So again, this is the step. We're going to drain from here, and that's it. We don't drain over the disc. Then laser or cryo. One or two breaks, I like cryo. It's very quick and very cheap. So cryo, and then that's here. Surgery finish, and we replace with 25% SF6 just to give us a bit of a more fill. So it's a segmental bucket that we converted to vitrectomy and cryo and SF6. Thank you so much.
Thank you, Dr. Ahmed, for a nice presentation. Let's assume another scenario that you went for the buckle. Okay, how would you? What's your plan? I mean, do you think if you just put the sutures are narrow in a narrower, not to get wider sutures, could have avoided the vortex veins, or instead?
I think it's a great question, and I really don't know. I thought I could not do it, and I thought it's just not going to work. And I re-looked at the video several times. I mean, thinking could I have like undermined it, but I think I would not be able to do it. I think I could have done it without cutting the vortex vein, which probably is the important thing. And maybe when I showed the video to several colleagues, they said one vein is not going to cause a problem if you just press on it. But I really did not know, and it took me by surprise, and I didn't know what to do. That's why I converted the situation. But yeah, I would love to hear from you and the other panel.
Talking about a complication. So if, God forbids, you had some injury to the vortex vein, what's your management then?
I honestly don't know. I've never encountered this situation. I think as long as you don't cut it, but I think if you cut it, it may bleed in the eye. I really don't know. I mean, I think I would clamp it and diathermy, but I would love to hear from you and the others.
Any of the speakers we have today, Dr. Singh, Dr. Samir, Dr. Borden, has any encountered such a complication of having a vortex vein injured during buccal surgery?
Hello, everyone.
Okay, you can go.
Sorry. Thank you. Oh, thanks all for the invitation. I'm Arnaldo Bordon from Brazil. I myself never had this complication, but however, in our hospital, we have 12 fellows, and of course, they're learning, and we encounter some complications once in a while. So Once one fellow was doing a surgery with another preceptor, and accidentally he put the needle in the vortex vein and started bleeding a lot. What he did at that time, he put some with a Q-tip, a lot of pressure to the vortex vein and stayed there for like 4 or 5 minutes compressing, and eventually he stopped bleeding without doing diathermy as you suggest. So I think you can manage, bleeding in several ways, such as compressing or diathermy or even laser. Sometimes depends on where you are. So I think it's a rare complication, but it caused a lot of distress during the OR, and eventually you can stop the surgery. You even stop the surgery and schedule for another day. So.
Dr. Samir, I know that you do buckles, especially macular buckles, a lot. Do you encounter such a complication? How would you avoid this?
First of all, I would like to thank you for the invitation and thank Dr. Mohammed Al-Amri for the invitation. I would like to welcome my friend Ahmed Salam and Dr. Arnoldo and Dr. Devendra. I think Ahmed's case is a very nice case, and he had a very nice presentation. But I think the case is not a case of buckling, because the grade is post-equatorial. But I think it's very hard to put a buckle in that place. We can put buckles more posterior by using the macular buckle, but we put it between the lateral rectus and superior rectus. Okay, so we don't encounter in this place. It's away from the vortex vein. If there is any injury for the vortex vein, it is a hell in the surgery. It can cause choroidal detachment and can cause unstoppable bleeding. So I think Ahmed had done well, had managed very well the case. And I think that the case was from the first in my hands for vitrectomy more safe, because it's a very posterior break.
Yeah, I think, sometimes you think, actually, I can do this. It's and I think I just try to do more buckles. And I think if the vortex vein was not there, we could have easily got it on a nice radial buckle. But no, I agree. I mean, it's how the situation went. Thank you so much.
Yeah, I think can I add one comment? Yeah, thank you for inviting me. Am I audible? Yeah, I think I just quick question to Dr. Ahmed, that if this break was close to vortex vein, wouldn't laser would have been a better option? Doing cryo, I don't know what kind of injury cryo can bring to vortex vein also, but I would rather prefer doing sealing it from inside if it's close to vortex. And second, we don't do too many buckles here, but still, whenever we encounter this vortex vein, we go needle from the other side, the side which is attached to the thread, and we put that needle underneath the vortex vein, and this is how we negotiate the vortex vein. So we go underneath, but we don't go to taking the pointed tip underneath it. We go from the other side. Reverse needle.
I mean, I think, shall I reply for the point on the? I think cryo is absolutely fine. I mean, we never had any issues with cryo on the vortex vein. I think 1 or 2 breaks, cryo is very good, really. And I don't think there's evidence to show even like that cryo increased PVR for 1 to 2 breaks. It's just very quick, very cheap. And it's just easy. You don't need to dry. I think more than that, then we definitely laser. That's what we tend to do. It's just very quick.
Yeah. Dr. Awadallah, you have to unmute yourself.
Okay. Sorry for that. So I used to hear from the masters of implants before they were doing implants, clear implants. They put in a pocket. They used to ligate when they encounter the vortex vein. They ligate the veins and you use diathermy. But again, at that time, we didn't have such, safe vitrectomy surgeries. But I think what Dr. Ahmed did is just great, converting to vitrectomy on the spot. Thank you, Dr. Ahmed. And let's move to Dr. Mohammed Samir presentation. Next, Dr. Mohammed Samir is a VR consultant at Alexandria University in Egypt and Harvard associate. Please, Dr. Mohammed, can share your screen.
Okay.
Okay. Yes, we can see your screen now.
Okay. Thanks again for the invitation. I will talk today about a very common complication and a very common backfire of the diabetic vitrectomy, which is bleeding. How to attack this bleeding, how to attack this problem. We have preoperative maneuvers, intraoperative, post-operative maneuver. The post-operative maneuver are directed to decrease the post-vitrectomy vitreous hemorrhage. The preoperative maneuvers mainly considers the preoperative systemic evaluation, blood sugar level, blood pressure, bleeding profiles, anti-VEGF and PRP, and I'm going to speak about them later, and the anesthesia. The local anesthesia plus sedation is more preferable than the general anesthesia, because general anesthesia tends to decrease the post-operative blood pressure. This decrease in the post-op blood pressure while awakening the patient opens the blood vessels and invites the post-vitrectomy vitreous hemorrhage. So its local plus sedation may be better in these situations. Here I have, according to the preoperative assessment of the patient, if the patient is on anticoagulant coagulation therapy. This paper has concluded that the patients undergoing diabetic vitrectomy who are on anticoagulant or antiplatelet agent do not exhibit a higher risk of intraoperative or post-operative hemorrhage. So it may be safely continued during the operation without stopping, and at the same time you may put the patient to the complication secondary to their initial disease or systemic disease. So in my cases, I don't stop anticoagulants or antiplatelets during the surgery. What about the anti-VEGF usage in these cases? Another paper or literature review, antivascular endothelial growth factor therapy for PDR, it concluded that the use of anti-VEGF agents before the PRP, or in our situation here before vitrectomy, may decrease duration of surgery, may be associated with fewer breaks and less intraoperative hemorrhage. Although there is evidence for decreased incidence of early post-operative hemorrhage, the quality of evidence is low. The available data therefore support the anti-VEGF agents as adjuncts to the PRP and pars plana vitrectomy may decrease the intraoperative hemorrhage during the surgery and the post-vitrectomy vitreous hemorrhage, and decrease the rate of break formation during the surgery. And as we all know that the anti-VEGF injection before the surgery by maximum 48 hours or something like that, it facilitates the dissection of the fibrovascular membrane and it decreases the incidence of intraoperative bleeding in vitrectomy. Intraoperative bleeding during vitrectomy for traction retinal detachment with and without the preoperative anti-VEGF, which the IBETRA study, it concluded that the preoperative intravitreal bevacizumab injection was associated with reduced intraocular bleeding during 23-gauge vitrectomy in macula involving traction retinal detachment. And there's other randomized controlled study with intravitreal bevacizumab injection 1 day before surgery for the proliferative diabetic retinopathy, and concluded that the intravitreal injection of bevacizumab 1 day before the operation blocked the vascular endothelial growth factor production in vitreous and significantly decreases the incidence of reoperation due to post-operative recurrent vitreous hemorrhage. And this paper was published in Retina 2015. So this was the attacking of the vitreous bleeding during diabetic vitrectomy before surgery. We are going now to discuss the hemostasis during the battle itself. We can elevate the infusion pressure. We can do thorough endodiathermy to bleeding points, good shaving, good membrane dissection without leaving of fibrovascular islands, good segmentation, diathermy of the vascular edges, and decreasing the IOP at the end of the surgery to check bleeding points and attack these bleeding points at the end of the surgery with low IOP by endodiathermy. Preventing post-operative hypotony, which is very important to close the sclerotomies and to be sure that there is no leak from the sclerotomies, and preventing post-operative cough or vomiting by the aid of the anesthesia consultant. So this is a video showing the how to do the shaving. It's about 6,000 to 7,000 cuts per minute, and with 150 millimeter mercury, extending to all the vitreous base, like we are seeing here at after performing the core vitrectomy. In this case, this is a case of combined traction rheumatogenic retinal detachment with subretinal blood, as we are going to see here in the video. So how to stop the bleeding points? This part of the video will show the power of air in doing the hemostasis, as we are going to see now, converting to air fluid exchange, and getting, this is the main break, getting the viscid subretinal fluid, which is like the viscosity of the vitreous, as we're going to see here, and elevating the blood, elevating the pressure of the infusion. This part you can elevate to 80 or 100 millimeter mercury to 1 or 2 minutes to stop the bleeding, especially the bleeding from the retina artery and retina central retinal artery and veins. This is another video. We have always a debate about the stump, the optic disc stump. Is it better to leave the stump or it's better to remove it? In this video, you will see that removal of the stump will induce a bleeding, and this bleeding may be unstoppable bleeding. So in my opinion, it's better to leave it, but doing diathermy at the vascular edges of this stump will be better, because it will cause the central retinal artery and vein or central retinal vessels bleeding, as we are going to see here, and it may continue bleeding for a good amount of time, even by doing every maneuver to stop the bleeding. Here I use the air as a tamponade, as a hemostatic element, by elevating the pressure to 80 to 100 for 1 or 2 minutes, and it stopped the bleeding at the end of the surgery. And at the meantime, securing the sclerotomies at the same time is very important, because securing the sclerotomies will prevent hypotony, and this hypotony will invite post-operative bleeding. And in this case, after I finish, I left the patient on air, and I inject intravitreal bevacizumab as well at the end of the surgery. This case, as we see here, with multiple bleeding points, with subretinal bleeding points. At the end of the surgery, I used to do hemostasis using the BFC. The BFC will do a third hand job. It will decrease the bleeding points at some extent, and at the same time, it will help removal of this broad blood clot submacular, as we are going to see in the video, and remove this huge blood clot, just submacular blood clotting, as we see in this part, getting it out and using the BFC as a third hand to fix the retina and stabilize the retina, and doing vitrectomy to this huge blood clot, and after that using the air and doing laser at this retinotomy, and at the end putting silicone oil tamponade. And this is the photo of the patient at the end of the surgery. This is another patient after closure of the sclerotomies. Some hypotony occurred, and leaking hemorrhage had dribbled from the sclerotomies to the macula and to the optic disc, as we see here. And the patient is, I think, silicone filled. So I entered again. Sorry, the patient was air filled. So I entered again to remove this hemorrhage, this blood dribbled through the sclerotomies, and I used here. This is not silicone. This is viscoelastic material. I put this viscoelastic material through the float needle. I put the float needle on the viscoelastic material, and I injected this viscoelastic material over the optic disc and the macula. Even if any other dribbled blood occurred, it will be away from the island of the viscoelastic material at the early post-operative minutes. Something is very interesting in these cases. In post-vitrectomy vitreous cases, you can be confronted by post-vitrectomy hemorrhage and hyphema at the same time. We are used to this, but at some times you may be confronted with something else, which is a surprise. So what is this surprise? This is the amalgam. This amalgam is very, very hard to remove and very, very sticky to the retina. And once you started to remove it, you will remove about 1/3 or 2/3 of this amalgam, and at the end you will be confronted with the anchored parts to the retina, and you will do by a very high percentage a break in this part if you are going to remove it all. So my advice is not to remove it all, as you are going to see now, because removal of the base of this amalgam is very dangerous and more hazardous to the retina, and it will cause many breaks, as we are going to see here. I'm trying to dissect it by the PIC 23 gauge dark PIC, but at the end I left the part away from the macula and put after that silicone oil tamponade, and this is the wise maneuver to get out from this trouble. I had many cases before that. I tried to remove this amalgam, but I failed, and I did many breaks, and it ended not much well like this case. Some people think that, or there is misconception that silicone is always the good solution for this post-vitrectomy vitreous hemorrhage, but this is not the truth, because you can be confronted by a sub-silicone bleeding like this case, which will be trapped behind the silicone, and this trapment behind the silicone is sometimes make what's called fibro or perisilicone proliferation, or sub-silicone proliferation, which will be difficult to remove, as we are going to see here, which is another surprise for the cases of silicone oil injection, that we may put silicone to decrease, in our conception, to decrease the incidence of post-vitrectomy vitreous hemorrhage. And as we're going to see here, there is here a break, and if I continue like this, it will induce more breaks. So I just remove the parts attached to the macula to free only the macula and leave the else parts. Is there new techniques for the hemostasis during diabetic vitrectomy? Yes, there is new techniques. For example, there is what's called the end aspirating laser probe. This is an end aspirating laser probe. It is a probe like float needle. It's aspirating. It will aspirate the hemorrhage, and at the same time will do the laser at the same time, because sometimes we have a bleeding, so we can't do laser while there is an active bleeding. So this instrument is like end aspirating fluid needle with a laser probe at the same time. So removal, aspirating the blood, and doing laser at the same time, and it was developed by Chang. Another thing is the simultaneous blood aspiration and laser coagulation. Other than the aspirating laser, we have a coagulation laser, not the PRP laser, the last slide. We have aspirating probe with laser coagulation of the bleeding terminals. So it uses the laser to act as a diathermy with the blood aspiration. So it's fluid needle, for example, and at the same time, laser coagulation of the bleeders. This is the second instrument. And there is what's called disposable 20-gauge bipolar endo-illumination, in which it is endo-illuminator, and bipolar at the same time with illumin, but with excellent illumination. So it gives us a good illumination, and at the same time gives us a bipolar diathermy. And thank you very much. That's what I have for attacking the diabetic vitrectomy bleeding, and I am welcoming any questions.
Thank you, Dr. Samir, for your nice presentation, the challenging cases. I think intraoperative bleeding with diabetic vitrectomies is quite a challenge. Let's hear from any of the panel, any comments or tips regarding this. Start with Dr. Salam. Do you have any tips for managing such bleeding, Dr. Ahmed?
Yes, I think the first thing starts before the surgery. So in addition to what Dr. Samir said about anti-VEGF, which I like it, it's important to tell the patient that 60% of the patients would have bleeding after the surgery. I think this makes a big difference.
That's very good. That's a very good point, Dr. Ahmed. Yes, I usually tell the patient that 50 to 60% of diabetic vitrectomies will have post-operative post-vitrectomy vitreous hemorrhage. That's very nice.
And I think that makes a big difference, so that they are not panicking, and also when you tell them after the surgery, you're not just surprised. And I tell them about 10% of those 60% will need resurgery, full stop. So I've made my life easy. The second thing, I think less is more. I use diathermy. I diathermize only the proud things. So if something is standing proud, I may put diathermy, but I don't like to diathermy flat things on the retina, because I think it increases the risk of retinal tears. And I try to just dissect reasonably. I wouldn't attack everything. And in my mind, I want to get out of there quickly, avoid breaks, and avoid using oil. And I think that works. And I think bleeding is going to happen, whatever you do. And I agree with Mohammed that bleeding in an air-filled eye is much better than bleeding in oil-filled eye, because you get this membranes under oil. I mean, oil in diabetics is terrible, really. So these are my...
Great. According to the diathermy, I want to add, Dr. Abdullah, please. According to the diathermy, you can adjust the diathermy before usage. You can try it at the fibrovascular membrane or something like that, or fibrous tissue, just to diathermy, just to have a very faint mark. It will do. Okay. But heavy diathermy, of course, as Ahmed said, it can cause a atherogenic break for the retina.
Good points, Dr. Samir. Let's go ahead with presentation of Dr. Arnaldo Bordon. Dr. Arnaldo, would you please share your screen? Dr. Arnaldo is the head of retina and vitreous sector in Sorocaba Eye Hospital, Brazil.
Oh, thank you. I think we need to unshare the screen so I can share my screen.
Yes. Okay.
Well, first of all, meanwhile, I would like again for the kindly invitation to participate in this meeting. And so far, I've been learning a lot with all you guys. I'm going to share some experience with you.
Samir, can you stop sharing the screen, please?
Yes, I'm trying. It's something wrong. I have a glitch. It's not okay. Okay. Yes.
Okay, now. Yes.
Yes. Okay now.
All right. Let me start here. So, can you all see my screen?
Yes, we can see now.
All right. So, I put in the, okay, now in the full screen. So, the hospital that I run, the Retina Session, is a teaching facility. And it's very good to teach because you learn a lot. You learn from the questions, you learn from the everyday challenges. And of course, during the OR is the part that you learn really, really, really a lot. I'm going to start with this case. I'm going to talk about with some perfluorocarbon complications that you can see and how things may lead to another, and you can see the surgery turning to like a test to your heart condition. So if you have a good heart and you pass through some surgeries, you don't need to check with your cardiologist because you already done. So this patient, this is a reoperation. This patient had a retinal detachment, and the retina was pretty much all attached except for the inferior part, as you can see. But this patient had some bubble of perfluorocarbon underneath the retina, exactly underneath the macula, as you can see here. So at this point, we start to displace the bubble inserted with the 38 gauge needle and displacing even further, putting some perfluorocarbon. So as we did that, some part of the bubble underneath the macula were moved away, but there is some still parts. So we did some air fluid exchange, no good. We were back to fluid, and as you can see, the retinal detachment increased. And then we did another bubble and try again to do under air to drain that fluid underneath in the peripheral area, as you can see. But again, no luck. So as you try to reach, you see there's a lot of lesion from the previous surgery. And meanwhile, when we were just exchanging instruments, when we went back inside the eye, look at how was the detachment. So what we did, we drained the fluid from underneath the retina. And as you can see now, it starts subretinal bleeding. So one complication led to another one, to another one. So to avoid the blood to go to the macula, we put some perfluorocarbon, and just to prevent that the blood goes there. And after everything, the retina finally was attached, and we did some laser. We didn't try to remove this blood because it was in the inferior part, and we thought we would make a lot of worse to the condition, to this eye, instead of making any good. So since it was inferior, we let like this. I'm going to move to the second one, the second video. This patient had surgery before, and this patient has a coagulation problem. As you can see, there's a lot of blood from the conjunctiva. The pupil was small, narrow, with several opacities in the posterior capsule. So this patient had silicone oil and a large amount of perfluorocarbon left in the eye in the previous surgery, about 30 to 40 days before this surgery. So we start, of course, just cleaning, this blood from the conjunctiva and trying to make some good view by doing a capsulotomy. And you can see here, this is the actual view for the surgery. It's not a video that is in a bad quality, but we try to aspirate, remove the silicone oil, and then we are trying to aspirate the perfluorocarbon with a 33 soft tip, but no good. You try to remove anyone that removed perfluorocarbon during the surgery that you just put, you see that it comes very easily. But this one, look at the bubble. We are pushing, we increase the vacuum to 400 and nothing. The bubble was adherent and couldn't remove it. We couldn't take this out. So at this point, we try some maneuvers like to move the bubble, to rotate the eye, increase again the vacuum, but nothing. So at this point, I said to the fellow, well, we're going to lose another thing. We're going to use 18 gauge gel coat, so to go inside the eye and try to remove and see how sticky is this kind of perfluorocarbon, which I think is mixed and is somehow blended with the previous silicone oil that was left for 45 days, 40 days at least. And then remove almost all of them and go after the last bubble. And then we had some bleeding, of course, during touching. And finally, we were able to remove the last bubble of this sticky perfluorocarbon. So I would like to hear comments for you. I'm going to unshare my screen. So this is perfluorocarbon is a very good tool. And of course, we can discuss since how to prevent the perfluorocarbon to go underneath the retina, and when it's underneath the retina, how to remove it if you need to remove it. And this is for the first video. The second video, this was very unusual. I think I never saw this before. So because it's a mixture of silicone oil and a large amount of perfluorocarbon that was left in the eye for a long period of time, more than 30 days. And I believe that this make a mixture, a blend, and prevent us to remove the perfluorocarbon in the usual fashion that we used to do regularly. And with this complication, we move ahead and do another thing, and we were able to manage that. The retina was attached through all the time in the second video. So I would like to hear, the comments from the panel.
Thank you, Dr. Bardon, for such interesting cases, and you really need to check your heart condition before you go into such cases. So let's start with Dr. Singh. Dr. Singh? Why do you think a PFCL bubble would escape into under the retina during surgery, like as what happened with Dr. Bardon's first case? And how to avoid, in your opinion?
I think this every time we see this case of subretinal PFCL, all of us, I think we are surgeons, we keep telling ourselves that we need to go back to basics. But yes, is it easier said than done? You have to keep it as a single bubble and relieve the traction first, especially on the posterior brakes, and I think minimize the turbulence. I think use valve cannulas. If there is too much of turbulence, I think that can also create fish egging. And also depends on kind of cannulas you are using to inject PFO. I think that's again a very important. I think most of us have discussed this very frequently, that how to avoid PFO going subretinal. But this is, as I said, it is easier said than done. Sometimes visualization doesn't allow you to adopt all these practices, and there are a lot of dynamic things happening in OR. So it does go subretinal once in a while. We see this in almost all the meetings. I think in general, if it is subfoveal, I think that's very important, that then we have to remove it. not all subretinal PFO has to be removed. This is one thing I would like to say. And I have also encountered a case where PFO got mixed with silicone oil, and it is really bad. It takes a lot of time to remove it. So that means that if you have a retained PFO, then I think better you remove it thoroughly and then only you inject silicone oil, especially you are going for a resurgery.
Thank you, Dr. Singh. Dr. Salam, being a minimalist, as I know, so do you like to use PFCL in all cases? And is there a second question? Is there any reason nowadays to leave a PFCL in the eye for some time?
Yes, I've put there. We're trying to put a book together on as a manual of retinal surgery. So I've put there in the chat the tips that we put in one of the chapters about how to avoid PFCL going under the retina. I think the best thing is not to use it or to use it minimally. I use it only for PVR detachment and giant breaks. That's what I use it for. I mean, of course, you want to inject slowly and don't inject over traction areas and don't double dip. But I think it's like what do you call it? Like the Russian roulette. You'll keep using it and something would happen once. So I would use it very minimally. Yeah.
And have you encountered before a case with a mix of silicone and PFCL as Dr. Burdens and Dr. Singh? And what's your experience?
Yes, it is very difficult to remove it. And in England, we had access to heavy oil, so it's even worse than heavy oil. And I think, again, I would try to avoid using oil and PFCL as much as I can. That's really my advice. Some patients, giant retinal break, we sometimes leave PFCL as a tamponade. I think this is really a good technique as well. It makes life easy. But otherwise, I would use it in this context.
Okay, great. Thank you very much. Thank you, Dr. Borden. I think we have only less than 10 minutes left to go with Dr. Singh presentation. Dr. Singh, would you please share your screen? Thank you. Dr. Singh is the Medical Director of Retina Services IQ Subspecialty Eye Hospitals and President of Gurugram Ophthalmological Society of India.
Yeah, thank you, Dr. Avadallah and whole MUN team for inviting me once again. And it's a pleasure interacting with such a senior and experienced vitreoretinal surgeons. And once you told me that we'll be discussing intraoperative complications, yeah, first thing that comes to our mind is our own fellowship, and then now your own fellows. But because I thought, let me share some videos where they are the complications where we could have avoided them if we were a little more careful, or we would have been following certain steps. So I have tried to collect 4 cases to be shared with everyone. So this is again a very old video where we were actually operating a young patient with combined rhegmatogenous RD. Patient had retinal vein occlusion, and I'm peeling this ischemic retina, and as you watch, I think there is some dragging happening, and which I was ignoring. Here you will see, as I am trying to peel ILM, retina is getting dragged, and I am ignoring it. And this is almost going to give way, still ignoring, and you see this. I ended up creating a large macular tear in this ischemic macula. And you all know that nothing can be done now for this. Even this doesn't even need laser, but this will create a very bad macular scar. So I wanted to share this with everyone for this reason only, that these days also, whenever we have to peel ILM in ischemic retina, we don't do it routinely, but if there is a epiretinal membrane or there is a need to remove ILM, then the difference from that earlier video is we go slowly, and if there is too much dragging happening, then we just stop it, and we avoid that extremely ischemic area. So as here you will see in this combined rhegmatogenous RD and PDR patient, you can see there is a break underneath this regress neovascular complex. And what I am removing here is the posterior cortical layer of highlight. And again, going very slowly. And if the more the drag, slower you become. And if you feel that you are not able to feel it safely, just give it up. And when I'm going to now remove ILM, again, going slow. I think light pipe is a little more close than it should have been. And like you will see, I'll just peel around the fovea, but I will avoid this extremely avascular area because I know if I try to peel over this area, I'll definitely get a retinal break. So that was one case. You want me to stop here or shall I finish all 4 cases, Dr. Avadilla?
Yes, yes, sure. Yeah, you can go ahead, doctor. You
Right.
still have
So,
5 minutes.
yeah, I think I'll just quickly rush through. Another thing what we have observed is when we are now peeling for these PDR cases, I think pre-op OCT angio is also helping us. And if you are able to find small neovascular twigs at macula, that is the area where ILM is going to give you maximum resistance. So if you can localize it pre-operatively, just avoid that area. Somehow I was not able to find a couple of videos which have collected. I think that's again a very small tip to avoid macular tears during peeling these ischemic retina. Now, the case number 2 was a routine macular hole. I think we thought it will be a simple macular hole surgery, and it was going well. As you will see, routine PVD induction, and plan was to peel off the temporal macula and create a temporal flap and do inverted flap technique. The visualization was little compromised, and as you see, as I was just crossing this temporal area, I ended up avulsing a retinal vessel, which I didn't realize. I thought it's a minor ooze, which you often encounter during peeling. And of course, my assistant has raised the intraocular pressure, and uh, still you can see the disc is not pulsating, so it was not raised enough. And I am still busy peeling the flap and ignoring the blood. I was still trying to cover the hole with the flap. I finished the remaining part of peeling superiorly, and again, I'm just not doing anything for blood. And this is at that point I tried to flush it out, but I knew that it has now clotted. Again, it's a macular hole case. This amount of blood, gas, I thought probably it will work like an adjuvant. Let's not fiddle around too much. And I just left it, and the patient had no visual recovery for almost 3 weeks. Gas bubble also remaining very less, and it was almost looking like a endophthalmitis cases, but no reaction, nothing. So we went ahead to drain it, do a vitreous lavage, and you can see the amount of uh, clotted and fibrotic blood coming out. And when I went inside, it was like almost like in fibrosis bulbi interna with just within 3 weeks. And again, I'm trying to poke, but then I was fairly reminded of my last experience. I stopped there, but I was really worried about this clotted sub retinal blood at macula underneath the macular hole. And of course, at post-op 4 weeks follow-up, hole did close, but not a very good outcome. You can see outer retinal layers almost gone, and patient highly unsatisfied. And you can see when autofluorescence telling us that this macula is not seeing well. So I think one small message: don't ignore hemostasis even in macular hole cases. And this was one. This another case again, a progression of diabetic TRD, and you see this foveal drag visible. So we planned surgery, and I was going bimanual nicely, dissection, just like we do for all our cases. And now I realize that this is a thick sheet. I'll change my hand. Yeah. And at this point, probably I just forgot that I have a forceps in my other hand, and I started going unimanual. And till then it was fine. And here, as you will see, I just went through the retina. Even when I had forceps in my right hand, I was not using it. So this is something I would like to show the fellows. I think all experienced surgeons know that if you have a, you are bimanual, stay bimanual. I think it is much more safer in these scenarios. And then again, now I wanted to clear all the traction very meticulously around the brake. So we encountered another one. Normally what I do if I get a break in PDR cases, I do this diathermy of the edges. It will prevent subretinal bleeding. Otherwise it keeps on oozing. And by the time you finish, you will have a massive subretinal heme. So again, I think rest of the surgery like healing ILM and all was same. And although this patient did well, but still we had to use silicone oil just because of that break, 2 breaks. So the message is again, if you have started bimanual, there is no harm in going ahead bimanually, and I think go for with higher magnification when the adhesion is tighter and go slower. And this is the last case. I'll just show this again.
For the last case,
Yeah.
just very comments
quickly.
from
I'll just
very. Okay,
this
go
was
ahead.
actually very interesting case. I was removing an IUL. There was iris prolapse happening, and you can see there was a choroidal detachment. I thought probably my cannula has gone suprachoroidal, but I am inserting the light pipe. It was not the case. Now I realize that I am dealing with a suprachoroidal hemorrhage. So what next? And then I could stop the suprachoroidal hemorrhage, and we were really lucky that day. But question is, should we drain it then and there only, or should we wait? So in general, I think I'll skip the discussion part. And in this particular case, actually, I could drain it then only. And you can see blood coming out, but most of us would otherwise advise that let it be there, and we will go back, once blood has liquefied. So that's it. Thank you.
Okay, great. Thank you very much, Dr. Singh. Very interesting cases with complications and how to deal with them. We can have some. Dr. Amri, is Dr. Amri with us? We can have some time for comments from the panelists.
Yes. Yes, go ahead, Dr. Muhammad.
Yes. So we have the cases of Dr. Singh. Any of the panelists would like to comment on any of them? The first case with the ischemic retina, and we had this retinal tears after ILM peeling. Yes, Dr. Samir, go ahead.
First of all, thank you, Dr. Devendra, very much for your nice cases and their consequences. It's very nice. But I would like to ask you, is the ILM peeling for you is a routine procedure in your vitrectomy cases? I think we don't do this in our retina surgery community because the ILM peeling has complications actually. And if you are going to do ILM peeling to decrease the incidence of epiretinal membrane formation, for example, it's already very low percent, and the studies had found that there is no significant difference between removal or non-removal of the ILM peeling. So what's your regimen in removing ILM in a case of
I'll quickly answer it. I think if we go for proliferative vitreoretinopathy, especially PDR, my criteria for removing ILM is only if there is a new vascularization within the arcade, or if I have a new vascularization at disc. And especially if this new vascularization is still active, you have some vascular component, then I would definitely like to peel ILM, because it prevents ERM formations once this new vascular complex is going to regress. We presented a poster at ASRS a few years back on this, that what are the cases where we can peel ILM in PDR. In DME, I think I am not a big fan of peeling internal limiting membrane, and I agree with you. It has complications, more complications when you are peeling on a compromised retina. So my criteria is, if you have a neovascular complex within arcade, if intraoperatively or preoperatively, I have seen it. I'll go for ILM peel. Otherwise, I'll avoid it.
Okay, great. Dr. Burdon, do you have any tips for peeling ILM in very thin retina, whether the ischemic ones or the highly myopic eyes, where you have this very thin and fragile ILM? Do you have any tips or any technique you would like to add?
Yeah, this is very challenging because, in myopic patients, you have a thin retina. If you have an ischemic retina, it's also even thinner. So you are dealing with a, unfair fight between the doctor and the eye. So if possible, I try to start the peeling very as close as possible to the posterior pole. Why is that? Because the IOM is a little bit thicker in the area than in the equator and periphery. So if it's the case, I try to do this way. One can use some of the scrapers. I'm not a big fan of a Teno scraper, but I've used for some cases the finesse loop from Alcon, that you can just create a very thin edge to start the peeling, because the most difficult part is to create the edge. Once you create the edge, then the removal of ILM is safer and less complicated. So what I think I use as a tip. And sometimes what you can do, especially in macular holes, when you try to drag some IOM from the equator to the hole, especially in reoperations, where you don't have any more IOM around the hole. What I do is I just lift just a little an edge, and then I put some perfluorocarbon, and then I complete the peeling and drag underneath the perfluorocarbon the ILM to the hole. This is another technique. It's different from the case presented, but it's we're talking about difficult removal. So I think this is another thing to share with you.
Okay, great. Your last case, Dr. Singh, the interesting one with the choroidal, suprachoroidal or choroidal detachment. Do you think there is any reason that this should happen, and how to avoid such, horrible complication?
Even today, I had an OR, so I was telling my fellow same thing, that don't leave eye in hypotony for any amount of time. It's like we should always keep a watch. Like we are doing vitrectomy, we are watching optic nerve head. We don't want to create pressure-induced damage, and this is just opposite of that. You should always keep a watch for hypotony, and this is very common when you have extended the limbal wound. Whenever you are doing any manipulation in anterior segment and you have extended the wound, sometimes you are waiting for something. This is probably the first and maybe I hope the last time I have encountered suprachoroidal. But a lot of my colleagues who refer to me, their story goes like this. I was waiting for an instrument. I have extended the wound. I was waiting for cutter. I was waiting for IUL. And this waiting, and patient getting anxious, blood pressure shooting up, and hypotony not addressed. I think these are, and a high myopic eye. This all makes a right combination for landing into a suprachoroidal. So high myopics are even much more sensitive. I think even if you have a 2 millimeter wound, yeah.
Also, elderly patients are more prone to such complication. I guess also you should have an eye on the systemic blood pressure on the monitor. Sometimes you find the shooting, especially if local anesthesia is kind of not deep and the patient is irritated, moving, and the patient gets anxious once some instrument forget to look after the wound. So you get hypotony from one side and high systemic pressure from the other side. Dr. Salam, God forbid this happened. What would you do or advise your fellows to do or teach them to do immediately if on the mere suspicion of getting a suprachoroid?
I just close quickly. We can always come back. Just close quickly. I mean, there's actually a great study from Taiwan that showed even during vitrectomy, it doesn't happen during the first vitrectomy. It's usually in vitrectomized eye when you come to do something. And I presume this may have been a vitrectomized eye. It's usually in this context. So I would just close, and then we can sort out things later, but close.
Okay, great. So any comments from the from any of the panelists or speakers, or before we conclude this great session?
Yes, just a quick comment about the suprachoroidal. You can happen also. I teach my fellows to always look up for the infusion line, because sometimes with movement of the eye, they tend to move a lot the eye, and then the infusion can be a little bit outside, but not totally outside the eye, and goes under the choroid, and then you start a big and sometimes massive choroidal effusion. It's not with blood, of course, with BSS, but it caused a lot of trouble during the surgery. And sometimes you have to stop the surgery. But I agree with Dr. Salem. When you encounter like this, I had the opportunity, not a good one, just like Dr. Singh, once in my life, and you have to close as soon as you can, as faster as you can. So just to make, the pressure and everything inside the eye. Otherwise, you have, completely disaster.
Thank you, Dr. Wallens. Great point. Okay, I think we came to an end of this great session. We learned a lot from complications as usual. And as I have said earlier, the more you do and the more you do surgeries, you encounter complications. And what makes a good surgeon is how to deal with such complications. Finally, thank you, Dr. Amri, for allowing us this opportunity. We had a great surgical session with the great pioneers from all over the world. Thank you. Thank you very much.
Thank you, everyone.
Thank you very much.
Dr. Amri. Thank you,
Thank you, Dr. Abdullah, Dr. Ahmed, Muhammad.
Thank you.
Thank you,
Very
everyone.
much. Dr. Bendra. Thanks for all.
Thank you.
Thanks for Dr. Mahmoud Ismail. How are you?
أهلا وسهلا. كل سنة وحضراتكم طيبين. Thank you very much for including me in your fantastic and outstanding retina discussion.
Are you going to work with
our cousins from
خلاص؟
دكتور حسين ودكتور عوض الله ودكتور محمد سمير، الناس كلهم الحبايب كلهم. Thank you very much for including me with you.
كل سنة وحضرتك طيب.
طيبين. أهلا وسهلا.
Dr. Mahmoud Ismail, for those who don't know him, he is the head of the Egyptian Ophthalmological Society, which is the older society of mother society of all ophthalmology in Egypt. Thank you for attending, Dr. Mahmoud. It was our pleasure.
شكرا يا باشا.
You can join us also. We'll have Dr. Mahmoud now as a speaker, as a guest of honor for the coming 30 minutes, inshallah. It will be an honor to be all of you with us. Thank you.
Thank you.